Hi, everybody. Thanks for being here. Anybody who is planning on engaging in Twitter with this talk, I can be found at Zachary at FAAEM. And here we go. So my brother was diagnosed with cancer a couple of years ago, and when he was getting chemotherapy, I asked him, are they prescribing you anything for nausea? And he said, I can't pronounce the name of the medication, but it sounds like the name of a dancing robot. And I thought that was a really good explanation for us. So we love Ondansetron. It is our most popular antiemetic. We give it for everyone who's vomiting. My nurses will ask me, can I give this patient ZOFRAN before I've even seen the patient? But it's not the only antiemetic that's out there. And even though it's a great antiemetic, I think that we probably can treat vomiting a little bit better if we try to treat the underlying cause with specific medications targeting at that cause. So in order to do that, we need to know where vomiting comes from to begin with. And vomiting starts at the vomiting center, which is in the medulla oblongata. And there's 4 different parts of the body that send signals to the vomiting center that cause a person to vomit. And we're going to talk about each one of those 4 areas because the place where that signal to vomit originates from is going to help you decide how to treat it. So the first area is the chemoreceptor trigger zone, which is at the base of the skull. A lot of different neurotoxins and inflammatory markers, when they come through the brain, they stimulate this area and cause vomiting. This is why patients with DKA vomit. So there's a couple different neurotransmitters that work at this site. And knowing the specific neurotransmitter is important because that's how we can decide which medication is going to be best to work on that area. So for GI-related vomiting, so your patient with gastroenteritis gets inflammation and stretch of their GI tract. When that happens, there's vagal activation. It goes up to the vomiting center, and the patient vomits. This is mediated by serotonin and dopamine, specifically. So we want to use medications that are going to address that. In comparison, vestibular-related vomiting, your vertigo patient that just can't stop vomiting, that's caused by a completely different thing. That's caused by histamine and muscarine. So these are 2 completely different types of vomiting, so why would we treat them in the same way? Well, we shouldn't. The 4th area where vomiting comes from is a little bit more hard to understand. It's the cerebral cortex. This is your patient who's vomiting due to emotional stress, due to anxiety, fear. We don't really have a great understanding of where this type of vomiting comes from, but it's definitely the hardest one to control. Okay? So now that we have a better understanding of the different areas where vomiting comes from, we can talk about how we're going to treat it. And for the purpose of this activity, I want you all to imagine that the entire world store of Ondansetron one day just dried up. You no longer have access to ZOFRAN. You can't give it to your patients. So without that all-encompassing antiemetic, let's talk about how we can treat vomiting based on its underlying etiology. So we'll start with metoclopramide, probably the second most common antiemetic, and there's a good reason why. It works dopamine, serotonin, histamine. It basically covers all of the bases. It's great for GI motility-related vomiting. It's great for headaches and vomiting. It's great for vertigo and vomiting. This is a great thing to use. But there's another medication similar to metoclopramide that you might not be using for nausea and vomiting, and that's haloperidol. We always think of this as an antipsychotic or a sedative, but it has great antiemetic property. Many of you have probably used compazine for vomiting in the past, and haloperidol works the same way as a dopamine agonist to stop vomiting. I've had a lot of luck using haloperidol in a very specific patient population, and it's these patients, the patient that the vomiting is coming from the cerebral cortex. You know that patient, you've all had this patient, they're a little bit agitated, maybe there's a little bit hysterical, maybe you're thinking, there's not really a good underlying reason why this person's vomiting, but I can't get them to stop vomiting. Haloperidol is the perfect drug to use in that situation. And there's another one that you probably don't think of as an antiemetic, and that's benzodiazepines. They have been used as adjuvant treatment for nausea and vomiting and chemotherapy-related vomiting for years, but we hardly ever use it as an antiemetic in the emergency department. So if you've gone through all your other antiemetics and that patient's still vomiting, maybe they seem really anxious about the fact they can't stop vomiting, consider using a low dose of lorazepam. Antihistamines, same thing. We don't primarily think of them as an antiemetic, but promethazine or Phenergan is a commonly used antiemetic, especially in postoperative patients, and it's an antihistamine. Diphenhydramine has antiemetic property, okay? So these are really good for that vestibular-related nausea and vomiting, the vertigo patients that can't tolerate POs. For the ones who can, obviously we use meclizine, which again is another antihistamine. And then polamine, which we can give transdermally, we use for patients with motion sickness because it works on muscarine. So again, these are things that work in the vestibular system. One final patient population that's very special that we're going to end with talking about here today is that pregnant vomiting patient. How do we want to treat those patients specifically? Now, this woman is not upset because she's been vomiting throughout her pregnancy. She's upset because she just found out the Ondansetron that she's been taking throughout her pregnancy is going to hurt her unborn child. Well, let's be honest. There's no good data that links Ondansetron to birth defects. But that's not going to stop people from trying to scare all the pregnant women out there that it is, right? These are real. These all exist. So the good news is, for our patients who are worried about taking ZOFRAN during pregnancy, we have another choice. In fact, we have a better option. The American College of Obstetrics and Gynecology, first-line agent for nausea and vomiting pregnancy is a combination of doxylamine, another antihistamine, and pyridoxine, vitamin B6. You can get this in a combo pill called Diclegis, which is pretty expensive. So an easier way for most of our patients to do this is buy some over-the-counter doxylamine, Unisom, and buy some over-the-counter vitamin B6 and take them together. Now, if the patient needs something IV, you can consider an IV antihistamine, such as diphenhydramine or metoclopramide, as first-line agents. So let's wrap this up. There's a lot of different reasons why people are vomiting, and everyone who's vomiting is not vomiting for the same reason, so we shouldn't treat them all the same. And remember, there's a ton of antiemetics out there. Don't get caught using just Ondansetron. Use your full toolbox of antiemetics. And that's all I have today. Thank you guys so much for your time.